Welcome to our video on stress incontinence. Let's get started. Stress incontinence is defined as urine loss that occurs with elevated intra-abdominal pressure. Examples of activities that increase intra-abdominal pressure include coughing, sneezing, lifting, laughing, or even having intercourse. Now, as far as pathophysiology is concerned, this type of urinary leakage occurs when the intravesical pressure, or the pressure inside the bladder, is greater than the intraurethral pressure. And that can occur as a result of urethral hypermobility or the urethral sphincter being insufficient. Now, because these mechanisms are important to understand, I actually want to show you these. Now, intraurethral pressure is largely the result of the pelvic floor muscles and the tightened urethral sphincter, which provides support. Now, compromise of either of those structures can lead to a decrease of intraurethral pressure. Now, the intravesical pressure, so that in the bladder, is maintained by the smooth muscle of the bladder. And the nerves are also around to help control those functions. And the net effect in a healthy individual is that the intraurethral pressure will be greater than the intravesical pressure. And again, in a healthy patient, that will still be the case even when the intra-abdominal pressure gets high. Now, if the pelvic floor becomes weak from something like multiple vaginal deliveries or obesity, then the urethra loses its hammock of support, and then it becomes hypermobile. This means a decrease in intraurethral pressure. And because of that, when there is increased intra-abdominal pressure transmitted to the bladder, then the intravesical pressure exceeds the intraurethral pressure, and urinary leakage occurs. This mechanism is often described as stepping on a hose on sand, and where the hose is the urethra, and the sand is the weakened pelvic floor. The other structure that maintains intraurethral pressure is the urethral sphincter, as we mentioned before. So, another cause of stress incontinence would be insufficiency of that sphincter, and that can occur when patients have damage during pelvic surgery, like something that damages that sphincter. And as with the prior slide, when there's increased intra-abdominal pressure, that will get transmitted to the bladder, and then the intravesical pressure or the bladder pressure will end up becoming higher than the intraurethral pressure, and then of course urinary leakage occurs. So now let's move on to risk factors. Risk factors for urethral hypermobility include anything that just weakens the pelvic floor. Examples include multiple vaginal deliveries, as we mentioned before, or even obesity, or sustained high impact activity like running, or even a chronic cough. And when it comes to sphincter insufficiency specifically, this usually is the result of direct neuromuscular damage. For example, having pelvic surgeries. The clinical presentation includes a patient that has leakage of urine only during activities that increase the intra-abdominal pressure, such as coughing, sneezing, lifting, laughing, or having intercourse. And that's pretty logical, because we're calling it stress incontinence, not total incontinence. They're not just incontinent all the time. It's only when there's stress. So if you think of stress as just being anything that stresses the abdomen or causes you to flex your abdomen or those ab muscles. So anytime you do that, then that will cause incontinence. Now, in severe cases, patients may lose urine when they're standing or even walking. Those aren't very stressful activities, but you can see that the stress level doesn't actually need to be that high in order for the leakage to happen. So that would be severe. Now, a key way to distinguish this from other causes of incontinence is that these patients don't have any nocturia, they don't experience urgency, and they don't experience frequency. Remember, it just leaks when they flex their abdomen or increase that abdominal pressure. There's no time to even experience the sensation of urgency because it just leaked already because they coughed. Let's pause for a quick question. A 37-year-old female has stress urinary incontinence, constipation, and an irregularly shaped uterus. What is the most likely diagnosis? Okay, well, the most likely diagnosis in this patient is uterine fibroids. And the best way to diagnose this would be using an ultrasound. Let's draw this out. You may recall that fibroids are benign, smooth muscle tumors that grow in the uterine myometrium. For many patients, a plethora of these is present rather than just one. So usually you don't say the patient has a fibroid, although they may just have one. Usually it's fibroids, plural. Now, if they get large enough, those fibroids can compress the surrounding structures by virtue of causing the uterus to be abnormally shaped and enlarged. And if the bladder is compressed by that enlargement, then stress incontinence can occur because of the added pressure. Now, if the rectum is compressed, then constipation may result. And as you can imagine from this drawing, this would also give the uterus an irregular contour as described in the vignette. Okay, now let's move on to diagnosis. The diagnostic finding in these stress incontinence patients is the cough stress test is positive. In this test, the patient is asked to perform a Valsalva maneuver and then cough, and do this while the clinician observes to to see if any urine leaks. A more accurate way to perform this would be to first fill the bladder with 300 milliliters of normal saline, because you want to make sure that there's enough fluid in the bladder, and then you do the test. Because any patient with incontinence should have a urinalysis performed, we've actually mentioned here that the urinalysis is normal in stress incontinence. So you're not expecting anything from the urinalysis in these patients. The post-void residual volume, which looks at how much urine is left in the bladder after the patient attempts to empty it, is also going to be normal. And this is done with an ultrasound. Basically, you just ask the patient to urinate, and then you come back to the bed and you use an ultrasound probe to see how much fluid is left in there. And a normal amount of urine that should be left would be less than 150 milliliters in females, which really are the patients you're talking about here. But in males, it would be less than 50. Again, that would be normal. Now, the first thing to do to treat your stress incontinence patients is to strengthen that pelvic floor through Kegel exercises. That can help provide greater support to the urethra. Now, weight loss is also useful because it means you're decreasing that intra-abdominal pressure on the bladder. So it's pretty intuitive that way. An incontinence pessary can also be helpful, though this would require regular maintenance, and it's usually not well tolerated by patients because they have to keep a foreign object inside of them. Now, periurethral bulking agents can also be used, particularly when the stress incontinence is caused specifically by the sphincter insufficiency. Now, surgical placement of a mid-urethral sling is actually the definitive management. So if nothing else works, just go to surgery. Now let's draw some of this out to help make sense of the last three treatment options we discussed. So first, the incontinence pessary. This is a ring-shaped device with a knob on one end, and it's placed inside the vagina. The knob is positioned anteriorly, and that will provide support to the bladder neck and prevent the leakage of urine. Meanwhile, that ring encircles the cervix. And pessaries like this can also be used for pelvic organ prolapse. Now we'll turn to an image of the urethra and the bladder and the sphincter muscles to help illustrate how periurethral bulking agents will work. And again, these agents are used specifically for patients with sphincter insufficiency. But here's how it works. A synthetic material is injected into the submucosa of the urethra, and that helps reinforce the deficient sphincter. And the whole point of that device or that synthetic material is to provide circumferential support for the urethra. Now finally, the mid-urethral sling. This is the gold standard for correcting the stress incontinence, like we said. It's surgical. Typically when you think of surgery, you're thinking last resort, and that's the case here. If you really want to fix it, you got to do surgery. And when performing a mid-urethral sling, the surgeon uses entry points at either side of the urethra to pass a V-shaped mesh underneath the urethra. And this serves as a new hammock to actually support it, to support that urethra. And the reason this is the gold standard is because the rates of success are very, very high. Now here's a review table that summarizes a lot of the information that we covered in this lecture, the important points, so this would be the bottom row for stress incontinence, as well as items covered in an earlier lecture about transient incontinence, which would be the top three rows. So you can use this to keep the differential diagnosis of incontinence in the back of your mind. And we'll build on this as we progress through different lectures. Now let's wrap up with a board-style question. A 39-year-old woman comes to the physician due to intermittent involuntary loss of urine. She first noticed urine loss 1 year ago, and it has recently become more frequent. She loses urine when she laughs or strains. She has had 5 successful vaginal deliveries. Her vital signs include a temperature of 37 degrees Celsius, a blood pressure of 110/80, a heart rate of 87 beats per minute, and a respiratory rate of 15 breaths per minute. The physical exam reveals urethral hypermobility with post-void residual volume of 100 milliliters. Urinalysis is normal. Which of the following is the best next step in the management of this patient? Okay, so this patient has intermittent involuntary loss of urine, and she loses urine when she laughs or strains. And these activities increase intra-abdominal pressure. Therefore, the most likely diagnosis in this patient is stress urinary incontinence. And that diagnosis is further supported by the fact that she has had 5 successful vaginal deliveries. Generally, multiple vaginal deliveries contribute to pelvic floor instability and stress incontinence. But what's the next best step in management? Well, what you would try to do is strengthen the pelvic floor muscles with Kegel exercises. After all, she hasn't tried anything yet, so you want to start in a stepwise fashion, becoming more and more severe or more advanced or invasive. So you'll only want to progress to more advanced or more invasive procedures only after those other items, like Kegel exercises, have been tried and they don't work. So the correct answer here, the next step, would be A, Kegel exercises. So just to go back to this management slide, recall that first-line therapy includes Kegel exercises and even weight loss. Now let's discuss why the other options are incorrect. Option B is incorrect because antimuscarinic agents are used for urgency rather than stress incontinence. Option C is incorrect because intermittent catheterization is performed to treat overflow incontinence. Now finally, option D is incorrect because a mid-urethral sling procedure is the last resort for the treatment of stress incontinence. So taking a step back, you're going to want to try Kegel exercises before surgery. And that concludes our lecture for stress incontinence.